In the UK every year, around 2,000 patients contract MRSA bacteremia. And 25,000 are diagnosed with Clostridium difficile. Just 2 of the many healthcare-associated infections that can be caught. The results can be fatal. Nobody is immune. It could be someone close to you, or even yourself. These bugs are smart, but together we can outsmart them because many infections can be prevented. The purpose of this program is to show you how you can play your part. There are 5 main ways that we can fight the infections. Through rigorous hand hygiene, by using aseptic no-touch technique, or ANTT, through the correct use of personal protective equipment, or PPE, by keeping the ambulance and the patient equipment scrupulously clean, by ensuring the safe handling of waste, linen and laundry. We're going to look at each of these. Good hand hygiene is the most effective way of preventing the spread of infection. Diarrhea and vomiting infections are often spread by the fecal-oral route, usually caused by hands contaminated with fecal matter touching your mouth. Fecal matter could also be present in food that's been prepared by someone who's simply not washed their hands properly following a trip to the toilet. Like this man here. He hasn't removed his long-sleeved clothing or his watch. And look at how much of his hands actually come into contact with soap and water. Using the glow box reveals many areas on his hands that haven't been cleaned properly. The recommended way to clean hands is shown on posters next to all hand wash sinks. First, you need to remove your watch, and if you have them, roll up long sleeves. Wet your hands under running water. Apply enough soap to cover all your hands. Rub your hands palm to palm. Rub the back of each hand with the palm of the other hand. Rub palm to palm with fingers interlaced. Rub with the back of fingers to opposing palms with fingers interlocked. Rub each thumb clasped in your opposite hand using a rotational movement. Rub the tips of your fingers in the opposite palm in a circular motion. Rub each wrist with your opposite hand. Rinse your hands with water. Turn off the tap with your elbow. If the tap isn't suitable, use a paper towel. Dry your hands with a single-use towel. Hand washing should take 15 to 30 seconds. Remember to clean your watch with a sanitizer wipe before you put it back on. When soap and water aren't available, you must use a hand sanitizer. However, alcohol sanitizer isn't effective if the hands are visibly soiled. So, use the wipes on the vehicle to remove any dirt and debris. Then, use the hand sanitizer. There are 2 levels of asepsis. The top level, the fully sterile approach, can only be used in areas where the environment can be fully controlled, such as in operating theatres. The second level of asepsis, used in normal hospital wards and the ambulance service, is called aseptic no-touch technique, or ANTT. The asepsis or cleanliness is achieved by not touching key areas of equipment, the patient's insertion site, and any open wounds. Cannula dressing packs like this one are routinely used to achieve ANTT. The outer layer is the sterile or clean field. The blue waterproof layer should be at the bottom, helping to keep the items inside the field clean. There's a paper towel. This is not to be used as a sterile field. It can be used to protect the area where an insertion is going to take place. Also in the pack, there's a ChloraPrep applicator for cleaning the insertion site, a dressing swab in case there's a failed cannulation, an IV fixing, and 2 sticky labels, one red and one green. The aseptic or clean field should be used to hold all items that have key no-touch areas, such as cannulas, syringes, needles, and giving sets. This pack is very versatile and can be used in many situations to help to maintain ANTT, for example, in the back of the ambulance. First, get all items ready, including the sharps box. Reduce activity in the area. For instance, if you're using the BP cuff, place it on the other arm to ensure that when the aseptic clean field is open, items aren't going to fall into it or knock it over. Place the single-use tourniquet in position and palpate the vein. Find the insertion point. Now use the hand sanitizer. Open the dressing pack. And position the paper towel. Use the ChloraPrep to clean the insertion site. Do not repalpate the vein once you have done this. If repalpation is required, then the area will need to be cleaned again. For full protection, the ChloraPrep, which contains chlorhexidine, must be left to dry for 30 seconds. While it's drying, open the cannula and place it onto the aseptic clean field. Then use the hand sanitizer again and put on a clean pair of gloves. The cannula can then be inserted into the vein and the IV dressing placed on, securing the cannula. The insertion site must be visible so that it can be checked in hospital for any inflammation or phlebitis. There are 2 stickers in the pack to alert the hospital staff if an emergency insertion has taken place. Red is for emergency insertions where full ANTT was not possible, in which case they need to remove the cannula and replace within 24 hours to reduce the risk of infection, as per the Department of Health guidelines. Green is for insertions where ANTT was achieved, meaning it's safe for the hospital to leave the cannula in place. So, red means remove, green means clean. This aseptic no-touch technique must be maintained throughout your treatment of the patient, such as when administering drugs or setting up a line. Retain the aseptic clean field. Open the giving set and place into the clean field. Close the luer lock. Open the bag of fluid or remove the seal, ensuring that the area where the point is inserted is not touched. To protect the patient, the key areas that must not be touched when setting up a line are the sharp end that goes into the fluid and the end that attaches into the cannula, and the part of the bag or bottle of fluid where the sharp point goes in. Insert the point into the fluid. Run the fluid through the giving set. Ensure the patient's end of the set does not touch anything other than the inside of the clean field, and the point on the giving set is not touched. Attach the giving set, making sure that it's only the key areas that touch each other. Then remove the cannula end cap. The same procedure can be used for giving drugs. Open the syringe, ensuring the key end does not touch anything. Open the drug-giving port on the cannula, making sure that only the key areas come into contact with each other. So, to reiterate, the key areas that must not be touched to achieve ANTT are the patient's insertion site, both ends of the cannula, both ends of the giving set, and the end of the needles and the syringe. Wherever insertion is required, the same ANTT process can be used. However, it's widely recognized that at times the patient's condition dictates that an emergency insertion has to be performed due to a time-critical, life-threatening situation. And, just a reminder, make sure the sticker doesn't obscure the view of the insertion site. The details of whether it was an aseptic or emergency insertion needs to be added to the patient report form and given to the receiving nurse. If there is a failed insertion, the sterile dressing from the pack must be used to cover the wound. When removing the failed cannula, it's important to remove the needle fully from the device before removing the device itself. This ensures the safety mechanism engages to reduce the risk of needle stick injury. ANTT can be followed in many situations, for example, in a patient's home. In other circumstances, follow as much of the ANTT as the situation allows. And always place dressings on wounds using a no-touch technique. PPE is very important for your safety and the patient's. Gloves, for instance. Don't overuse them. Only wear them when necessary. If you do wear them, just in case, as you get to a scene, then they must be changed before any patient procedures are carried out. The reason being, whatever has been touched on the way to the patient, like door handles, a doorbell, a letterbox, a gate, a cat, a dog, will now be on the gloves. They must not be worn while driving or on entering an A&E department, unless there's still a genuine need to be wearing them. You do need clean ones for IV insertions and to protect you from blood, body fluids and environmental dirt. Never write observations on the back of gloves, as this will encourage you to wear the gloves for longer than is safe and can contaminate other items and areas. They should be removed by turning them inside out and then disposed of as clinical waste. Aprons can be used to protect your uniform. To remove the apron, first break the top strap, folding this part down. The back straps then need to be broken and the apron folded in on itself, to contain any contamination that may be on the apron. Then roll it up and dispose of it as clinical waste. Sleeve protectors do just that. They're not sterile items, so can be kept in coat pockets, ready for use whenever you need them, protecting your sleeves from blood, body fluids and environmental dirt. For example, when fitting snow socks, sleeve protectors stop the dirt from the tires getting on your coat. They can be used in other circumstances too. To remove them, fold them down onto themselves and bin them along with the gloves into clinical waste if blood and body fluid is on them, or into black bag waste if there's just environmental contamination. Face masks are provided in the infection pack. Surgical masks can be used for patients who are coughing or sneezing and unable to use tissues. Ask the patients if they'll wear one. If they refuse or can't tolerate the mask, then you can wear it. If the patient is actively vomiting or spitting, or you are required to perform suction, then you should wear a mask with a visor for extra protection. The FFP3 respirator masks should be worn if you are transporting a patient with a known or suspected infectious respiratory disease, especially during an influenza outbreak. Plastic goggles are also in the infection pack. These can be used to protect your eyes from particles of light debris. It's not only you and your patient that you need to keep clean, it's the ambulance and all the equipment too. After each patient has been discharged from your care, you must clean all patient touch items. Most of the time, sanitizing wipes will be sufficient for the job. Think about what the patient touch areas are, such as the wall next to the stretcher, the carry chair, and if the patient was sitting in the attendant's seat, wipe the contact areas there too. The monitor leads, the SATS probe, and the BP cuff. If you know or suspect that the patient is infectious with something extremely virulent, such as Clostridium difficile or norovirus, and the patient has been symptomatic on the vehicle, then you may need to use specific cleaning products to ensure the vehicle is safe to be used for others. That could mean going back to base, but the receiving hospital may have what you need. So check first with the Emergency Operations Centre or the Hospital Ambulance Liaison Officer if there's one on duty. Clean linen must be used for every patient. You can do a clean for dirty laundry swap at the hospital. This way you can avoid carrying soiled laundry in the ambulance. However, if you do have to bring used linen back to the station, it must be put into a white laundry bag with the top tied for transportation. Any laundry contaminated with body fluid that has to be taken back to station, for instance after a home birth or a trauma that's been airlifted, must be carried in a red alginate bag. These bags have a seam that dissolves, so they'll split in the washing machine, releasing the clothing. However, this design does mean that the bags have a weakness, so they must also be placed into a white laundry bag to stop the contents spilling out during the journey. Then, when you arrive at the station, put this double-bagged linen into the contaminated laundry bin. When removing dirty laundry from a stretcher, don't be a blanket hugger. Put on a clean pair of gloves. Roll up the used linen. Hold it away from you, and then put it in the soiled laundry bin. Clinical waste must be removed from every ambulance at the end of every shift, regardless of where it's going next. Each bag must be sealed with a plastic tie and a label filled in with the station name, date and vehicle identification. Don't fill the bags to the max. 3/4 full is the limit, so that they can be securely sealed. At every ambulance station there's at least one large yellow clinical waste bin, with a lin bin attached to the wall, containing labels, spare bags, ties, and the key to the large bin. The bag can then go into the large bin. With sharps boxes, you also need to follow the same procedure regarding the labels. And they also must be placed into the same large clinical waste bin when they're 3/4 full. Food items and general waste must not go into the clinical waste stream. If you ignore this, then you failed in your duty of care for the environment. The Environment Agency does spot checks, and if they do find that non-clinical waste is being unlawfully disposed of, there could be a large fine to pay. So there you have it. 5 ways to help prevent and control infection. However, if your patient's life is under immediate threat, then cleanliness may not be your top priority. But remember, infection can also result in death. And these techniques are tried and tested. Follow them whenever you can. Then we in the ambulance service can keep those bugs at bay, doing what we do best: saving lives.